Make sure you never miss an FX Medicine episode by subscribing to us on Apple Podcasts, Google Podcasts, and Spotify. You can also follow us on LinkedIn, Facebook, and Instagram.
Hi and welcome to FX Medicine, where we bring you the latest in evidence-based integrative, functional and complementary medicine. FX Medicine acknowledges the traditional custodians of country throughout Australia where we live and work, and their connections to land, sea and community. We pay our respect to their elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Joining us on the line from Singapore today is Naturopath Ben Lee, a degree-qualified naturopath who has extensive training and experience in nutrition and herbal medicine. Ben has a special interest in skin conditions, particularly eczema. His personal journey of healing from severe, full-body eczema and topical steroid withdrawal guides his evidence-based approach towards treating eczema. Ben runs a busy clinical practice in Singapore, and he's also a consultant to eczema support groups and companies. He graduated with a Bachelor of Health Science in Naturopathy from Australia and obtained the Dux Award and the Award for Academic Excellence. He is part of an integrative clinic and collaborates closely with integrative doctors and allied healthcare professionals to provide synergy in client care. In treating skin conditions, Ben endeavours to eclectically adapt treatment strategies from naturopathic medicine, functional medicine and allopathic medicine. Today, we're going to deep dive into topical steroid withdrawal, which is also known as steroid cream withdrawal or red skin syndrome, and learn how to navigate this tricky clinical condition. Welcome to FX Medicine, Ben. Thank you so much for being with us today.
And thanks, Emma, for having me. And it's a privilege to be here. I think TSW is very close to my heart, and I'm happy to share about the protocols and about my own story about TSW.
Brilliant. I would actually love to start with your personal story and how that influenced your clinical practice. Tell us more.
Yeah, for sure. So for myself, I had severe eczema since a child, and for years and years, I was on many rounds of both topical and oral steroid creams. And each time the skin would get better, it would clear out for a while. But once I stopped them, it came back worse than before. And over the years, there was a trend in that I had to use higher and higher potencies of steroids. And each time they became ineffective or less effective. And I noticed this spreading redness and burning sensation. And it got to a point where I had moved on from class 1, which is hydrocortisone, to class 7, which is clobetasol. And at the highest potency, it just stopped working. And eventually, immunosuppressants were suggested as a next step. And I just realized that this just wasn't sustainable. And what happened was that at one of my lowest periods in life, I then discovered the works of Dr. Marvin Rappaport, who's actually a dermatologist. And he's one of the pioneers of TSW. And so back in 2003, he published a paper. And it mentioned how 100 patients with chronic eczema, they didn't get better until all steroids were stopped. And their story was like mine. They had used more and more steroids and increased the potencies, but it just didn't improve. And so similar symptoms, they had severe burning and spreading redness to local and distant areas. And that's what led me into my own journey and my own clinical practice in TSW.
And it's realistically, it's a story that we do see in clinic, that patients are using more and more topical steroids to try and get the same outcome, and then we get this rebound effect. And I feel like this is such a fascinating topic, and it really took me on a path of hours and hours of research. And what I did come to understand is that this condition is not well addressed in both the naturopathic world and the conventional medicine world, and we're really failing a subset of patients, who are experiencing chronic, severe symptoms. In a systematic review of eczema sufferers and their use of topical steroids, the topical steroid withdrawal affected 80% of the women, and an amazing 99% of the women said it affected their face or genitals, with the symptoms of redness, burning and stinging experienced by all the women. So, before we go any further, can you just give us a bit of a 101 on steroids, on their potency, their mechanism of action, so that I can understand this more?
Yes, sure, Emma. So, topical steroids, they work by a few mechanisms. First is vasoconstriction, and number two is they reduce inflammatory prostaglandins and leukotrienes, and they reduce cell proliferation. And so, many of my patients, when they come to me, they have perhaps the misimpression that when they jump from a class 1 hydrocortisone to a class 2 or class 3, they think that it is an increase of 2 or 3 times. But actually, if you compare a class 1 steroid to a class 7 steroid, so a class 7 is hydrocortisone and a class 1 is clobetasol, the jump is 600 times more potent.
Wow. Okay.
And so one way that, one measure of steroid potency is how strongly they can constrict the blood vessels. And so the higher we go, the stronger the vasoconstriction of the vessels.
So the higher the class, then the more potent the steroid cream?
Yes, and also the more potent the strength of the vasoconstriction becomes.
Right. Okay. All right. That makes sense. Can you explain what topical steroid withdrawal is, and then the main signs and symptoms and any triggers? And I'm kind of curious, why do women seem to be more affected than men with this?
Yes. So TSW is defined as rebound vasodilation from prolonged, inappropriate and frequent use of moderate to high potency topical steroids. So, for example, my patients, when they have been on clobetasol or betamethasone dipropionate for months on end, we do see a few things. We see that their skin happens to look more pale because of the blanching effect, because of the vasoconstriction.
Okay.
And then when it stops, then the rebound vasodilation happens. So I often tell my patients, imagine that you have a water hose, and this is like your blood vessel. And you clamp down on the hose for a long time, and then you just release it all of a sudden, and water gushes through, blood goes through, and then there's a compensatory rebound vasodilation that happens. And this is actually the pathophysiology of TSW, because more blood and more inflammatory mediators gush through the blood vessels. And so as a result, the patients get diffuse erythema, they get burning. Patients often say, I feel zingers everywhere. And they feel cold, they have thermoregulation issues, and you see oozing skin, you see all the interstitial fluid coming out, and you see edema. So if I may summarize this into an archetype of a TSW patient, what I see when they walk into my room, they are usually wrapped up in layers and layers of clothing, and they feel cold. And when they come in, they will say, please turn off the fan, turn the aircon off, I feel so chilly. You will sometimes see a classic red sleeve, so the whole arms are flush red, but it abruptly stops at the palms. And this is one of the key features of TSW, the red sleeve.
Okay.
The non-skin symptoms may be major fatigue because they haven't slept for weeks or months. And there's depression, anxiety, and also, not uncommonly, suicidal tendencies.
That's hugely impactful, isn't it? I mean, I know how I feel if I haven't slept for a couple of nights, let alone chronic sleep disruption. And I'd imagine that is feeding into that inflammatory process as well.
For sure, majorly, yes.
What is the underlying pathophysiology? You've kind of given me a broad sweep, but I want to kind of go deeper again. What's happening to the skin on a cellular level? What are the key underlying drivers that are happening?
Yes. So there are three drivers that are happening. So besides the nitric oxide increase that we discussed earlier, there are a few other areas. Firstly, there is a transient HPA axis suppression.
Okay.
This happens more commonly when very potent class 1 steroids are used. And studies in children estimate this to be around 6%, and it is reversible when the steroids are stopped.
Okay.
The second driver is skin atrophy, because steroids inhibit fibroblast activity and inhibit collagen synthesis. So many patients may see telangiectasia, they may see striae, thin skin, and so when they say that if I scratch my skin, it breaks so easily, and they will describe the skin as sandpaper.
Okay.
And the striae are a key feature. So you see these red indented streaks on the skin because of the skin thinning.
Okay.
Lastly, and perhaps what I see very often in my own practice is secondary infections, commonly bacterial. And I can't emphasize further how important Staph aureus is in the TSW pathophysiology, because Staph aureus produces alpha toxins and beta toxins, and these trigger major T cell activation. They penetrate through the epidermis and the dermis, and they trigger major inflammation.
Okay. Fascinating. So we have a couple of mechanisms. It's the nitric oxide that you mentioned earlier. We have the HPA axis suppression that is temporary. Then the skin atrophy due to the inhibition of collagen synthesis, and then the added layer of the Staph aureus colonisation. So there's a lot going on there.
A lot. And then also, I think, coupled together with the major nervous system dysregulation, patients are in sympathetic mode all the time, and they're stressed, they're depressed. It's a lot to handle.
And what else is the Staph aureus colonisation doing to the skin?
Yes, so if I may summarize, or if I may emphasize one point that I've seen give me huge clinical success, is that whether or not it's TSW or eczema, we must treat the staph. That is so important. And at this juncture, I wish to segue a bit about Staph aureus, because among adults with eczema, studies show that between 54% to 100% of adults have staph colonization. And it's not just on the skin. It's not just on lesional skin. It's also on non-eczema skin, and it also colonizes the nose. Okay. And so studies found that the extent of nasal staph colonization is also linked to eczema severity. And I reckon that perhaps there's some translocation of the staph happening. I also read this study that showed that how the gut staph colonization or gut staph overgrowth is also linked to skin staph overgrowth. And on this point, whenever I run gut microbiome tests in my clinic, I very often see, for the majority of eczema cases, high Staph aureus in the gut.
Yeah.
So if I may expand a bit more about what inflammatory mediators this can produce, Staph aureus produces, or Staph aureus entry into the epidermis is linked with increased interleukin-4, interleukin-13, and thymus stromal lymphopoietin, or TSLP. And IL-4 and IL-13 are two very important mediators, because if you see the biologics today, one of the most common ones that many of our patients may come in and tell us that they're on is Dupixent or dupilumab.
Yes.
And Dupixent works exactly on these two pathways, on the IL-4 and IL-13 pathways, and both of which are Th2 cytokines. And we find these two cytokines majorly overexpressed in eczema skin, and I'm sure in TSW skin also. They they do a few things. Their purposes is they actually stimulate the itch receptors and they increase neurogenic itch. They also increase transepidermal water loss and makes the skin dry. And they perpetuate this constant cycle of mast cell recruitment and makes the patients very, very itchy.
Okay, so just going back a bit, you mentioned a biologic. Now, I have had an increasing amount of patients over the last 6, maybe 12 months that are starting to use biologics. So I was just so fascinated to see how it was working, because I have to say they do seem to give good results.
Yes, they do actually. And also to cover at this point, I think as naturopaths, I think we are not against the use of biologics nor steroid creams, but it's only if it's used perhaps indiscriminately for a long term, then it may cause potential issues. So I have seen in my own practice that when there is a big flare-up, sometimes there's actually a role for biologics because it calms down, it breaks the cycle. And when the inflammation is calmed down, we can then go in with our herbs and nutrients to then support the inflammation. But when the skin is so flared up, sometimes the patient has so many allergies and sensitivities that we can't go in with any herbs or nutrients without causing a flare. So to circle back to your point, Emma, I fully agree that there is a role for biologics because, in fact, we can complement biologics and herbs and nutrients at the same time and make it synergistic.
Yes, and I do see that role as being quite powerful, and sometimes these medications can give us the space we need to start working on those underlying drivers.
Exactly, because the cycle must be broken somewhere, and sometimes when we have tried all the interventions naturally, sometimes the biologics may be the highest force interventions that we have to go to, and that's okay because I've actually seen patients win all biologics with the blessing of the dermatologist, and we have addressed the gut, addressed the liver, addressed the nervous system, and then this patient I had, after 6 months of biologics, her skin remains fully clear because when she was on Dupixent, we did all the internal work. And now her skin is fully clear.
Isn't that amazing? That's exactly the kind of case outcome that you want. Yeah. And anything else we need to know, in that space of the cellular pathophysiology?
For sure. So one other mediator that I think we should know is TSLP or thymostroma lymphopoietin. TSLP, so we have found, or studies have found, that the more severe the eczema, the higher the serum TSLP levels. And so TSLP activates dendritic cells and it promotes mast cell growth and survival. And therefore, this enhances the itching and the epidermal inflammation. So in summary, nitric oxide, IL-4, IL-13, and TSLP are among the main pathophysiological mediators of TSW and eczema. And we have, in fact, later on I'll discuss some herbs that actually work on these same pathways.
Yes, and we will be definitely diving into treatment and cover those. Before we go to the treatment side of things, how do we test for topical steroid withdrawal? Are there biomarkers that you use in clinic? How do we know when to test? Is there a diagnostic process for this? Because I find it confusing on this front.
Yeah, 100%, Emma. And there's no test for TSW, and it's mainly based on clinical signs and symptoms.
Okay.
And I had a few patients come to me, and they said, "Oh, Ben, I'm having TSW," but then we actually sent them to the GP for a swab.
Okay.
And we found that it was actually a bacterial infection. And once we cleared the bacteria, the skin cleared up within 1 or 2 months. It cleared really well, and they were able to swim, able to cycle again, and it was gone.
Okay.
So my first point is that I find that sometimes TSW can be mistaken for a Staph aureus infection.
Okay.
But for TSW, there are a few key clinical signs and symptoms. Number one, the red sleeve. So the whole arm flushes red, but it stops abruptly at the palms.
Okay.
Number two, but I don't see this so much in clinic. It's called a head-like sign. So the nose and the perioral area are spared from the erythema and the flushing.
Okay.
And number three is the elephant wrinkles on the skin. So the skin, you'll see many folds and and it's dry and sandpaperish.
Okay. So we've got the red sleeve where the redness stops at the wrists. We've got the headlight sign where the nose and the perioral area is not red. And then the elephant wrinkles on the skin, so an abundance of sandpaper-like skin. So no diagnostic criteria from a blood test perspective, but we're looking at those signs and symptoms.
Yes, that's right.
Now, if the condition is usually confused for eczema, then how do we differentiate between the two?
Yeah, that's a really good question, Emma. And so there are some ways to differentiate this. Eczema is usually on the flexus, so on the antetrabecular fossa behind the knees. And this is a very atopic presentation. TSW can be everywhere, can be anywhere. So you'll see a generalized erythema on the chest and the back, flushing everywhere. And number two is that, and I see this in clinic a lot, eczema patients, they don't report a burning sensation, but TSW patients often do.
Okay.
And they will say, I feel like I'm burning up. And some of them, they'll be in the bathtub for hours because they feel so hot.
Okay.
And lastly, eczema patients, they often have no issues if a fan is on them for a short while or if the aircon is a bit cold, they can thermoregulate pretty well. Okay. But in TSW patients, they feel cold at the slightest drop. So I recall one patient who came in the clinic, but she asked for 2 or 3 blankets, and she was wearing a jacket already, and she needed more blankets above the jacket because she felt so cold.
Yeah, that's profound, isn't it? Wow. So they're actually quite different when you look at it like that. That eczema is usually on the fold, like the elbow folds. Eczema patients don't say they're burning up, and they're not super sensitive to the cold. So I love that you've painted that clinical picture really nicely. Thank you.
Yeah, no problem. And I also wish to say that sometimes it is hard to differentiate because patients can have TSW plus eczema plus a staph infection all at once.
Oh, goodness. Now that's confusing. And I guess that's where getting a skin swab done to work out the first step is probably a good idea, right?
Yes, 100%.
Now, as complementary health practitioners, we, I feel, often have a bias for believing that gut health is the root cause of everything. But are we correct in this instance, or is this a classic case of confirmation bias? What are your thoughts?
Yes, so Emma, I think this is a great question. So in my own experience, in my own journey of severe eczema and TSW, many years ago, my own practitioners, and they were very good practitioners, they addressed the gut. They gave me glutamine, they gave me antimicrobials, enzymes, and betaine hydrochloride. But this had no impact on my skin at all. And in my own practice, I had a few patients come to me, and they had done the various gut microbiome mapping tests and SIBO tests, and they had addressed all the issues in the test, and the skin had no shift. In fact, it got worse. And they even flared with antimicrobials. So I think we often discuss the gut-skin axis, but the key point is that it's actually bidirectional. So let me talk a bit about the skin-gut axis instead.
Okay.
So some studies have shown that food allergy can develop through an impaired skin barrier. So, for example, when children apply a moisturizer with oats on the skin, this was linked with a higher rate of oat allergy, and there are even case reports in the literature about anaphylaxis.
Okay.
And so I advise my patients to be very cautious of putting food proteins like oats and goat's milk on the skin, which are very common in moisturizers and in body washes nowadays. Because when the epidermal barrier is impaired, the proteins enter the skin, the dendritic cells pick it up, and they trigger the T cell responses, and then it can then lead to a systemic allergy and even anaphylaxis.
Okay. That's quite fascinating, isn't it? I've just had a case of a little girl with eczema pop into my brain who had a similar thing with sesame. She had a skin gut reaction to sesame oil in a moisturizer. So it's really one to be considering.
100%, Emma. And to also build on your point, besides sesame, the research has shown that even eggs or peanuts, kids will apply peanut oil products on the skin. Has a higher risk of peanut allergy. So yes, you're right. Any food-based proteins on the skin can increase the risk of systemic allergies.
Okay, but first you need to have an impaired skin barrier function.
Yes.
Okay.
That's right. Okay. And so to build on to your point, therefore one of my top treatment aims is to repair the skin barrier. Oftentimes I think as naturopaths or as integrated practitioners, we go for the gut barrier first. But I think we must repair the two barriers concurrently.
Yes. So thinking about that and then thinking about the skin microbiome, how do dermal microbiome imbalances like Staph impact topical steroid withdrawal? And on the skin, Staph aureus has been dubbed a marker of eczema severity, and higher fecal concentrations have been found in eczema patients. But is it an issue with the pH? I mean, what exactly is going on here?
Yeah, so there are two things that are going on. Firstly is that our skin's pH should be around pH 4-6.
Okay.
And in this range, the skin can produce antimicrobial peptides like dermacidin, and it produces ceramides for the skin barrier integrity. And number two, on this point of ceramides, in many eczema patients, they have a filaggrin gene mutation, and there's some studies that show that this mutation can contribute to a more alkaline stratum corneum pH, and therefore the alkalinity favors the growth of Staph aureus. It impairs the stratum corneum integrity. So one thing I find useful in my practice is I'll ask patients to show me their palms. And there's a term called palmar hyperlinearity. And so if you see that your patients have very clear, deep lines in their palms, this may correlate, not always 100% for sure, but it can suggest it's a filaggrin mutation. And it means that these patients have a more impaired skin barrier, and they're more prone to atopy with more allergies and sensitivity.
Right. Because can you do a blood test for filaggrin gene mutation?
I recall seeing in the literature that there were blood tests done before, but I haven't seen it done in clinical practice. And usually I find that that if I see that the patients have the palmar hyperlinearity coupled with an atopic presentation, asthma, eczema, rhinitis, I often presume that they may have a higher propensity towards the filaggrin gene mutation.
Okay. All right. That's a good clinical tip. I'm going to start doing that one. Thank you.
No problem.
Now, I want to dive into holistic treatment. Can you take us step by step through the aims of what treatment should look like, about the order of treatment that we should be prioritizing? How do we treat this effectively?
Yeah, sure. If I may just add one step prior. So I think that oftentimes before we even assess or before we even treat TSW, assess whether it is TSW or not. So And as to build on our earlier discussion, have you done a skin swab for staph overgrowth? And also could there be other triggers? Let's say, could there be mold exposure? I had a patient that, she told me that after she cleaned a big moldy patch in her bedroom, she began having full body flushing, redness, cellulitis, and this actually mimics TSW.
Okay.
If we run a full blood count, do we see elevated white blood cells, which may indicate an infection? And also, where is the rash location? Is it the full body, or is it only on the head and neck? If it's head and neck, could the other differentials be, let's say, like seborrheic dermatitis? Could it be fungal and etiology? If it's more on the lower legs, could it be stasis dermatitis? Could it be an issue with poor venous return? So therefore, getting a proper diagnosis and being clear of our differentials is really important for treatment success, because many of my patients come to me and they have been perhaps misdiagnosed as TSW, but when it was actually staph, or it may have been a mycotoxin issue. So moving on to your question, Emma, there are 5 broad aims among many aims, of course, but first is support the endothelium.
Okay.
The main pathophysiology is the excess nitric oxide production. And because, going back to our water hose analogy, we have clamped it down for so long because of the vasoconstriction from the high potency steroids, and therefore when it's released, then nitric oxide increases, and therefore there's vasodilation, there's flushing, there's redness, there's erythema. So reduce nitric oxide and strengthen the leaky capillaries.
Okay.
Number 2, reduce Staph aureus levels to reduce the Staph aureus superantigens from entering the epidermis and dermis and triggering the T cell responses. Number 3, to calm down the TSW and eczema-specific inflammatory pathways like IL-4, IL-13, and TSLP. And because these are increased when the skin barrier is impaired. Number 4, support the nervous system and adrenals. I think this is where naturopathic medicine and integrated medicine really flourishes, because we can support the nervous system and help them through this period of intense stress. And number 5 is to repair the skin barrier, because if the skin barrier is repaired, then the antigens there'll be lesser antigen entry and there'll be lesser T cell activation. So the gut support, liver support that we do in naturopathic medicine is important still, but put down the fire on the skin first.
I really like that analogy. So the first step is, I guess, doing a skin swab for staph overgrowth and ruling that out. Second, it would be to distinguish if it's actually eczema or topical steroid withdrawal. And then if it is indeed topical steroid withdrawal, then we would first support the endothelium by reducing excess nitric oxide, strengthen the capillaries, then look at reducing the Staph aureus overgrowth, calm the inflammatory mediators like IL-4, and of course support the nervous system and adrenals and repair the skin barrier. So I find it really interesting that the gut and liver support is not at the bottom of the priorities, but you're right, you've got to kind of put the fire on the skin out first before moving to those deeper levels.
100%, Emma. And also, I've in fact seen that in TSW cases, and even in severe eczema cases, when patients are put on like milk thistle or liver support, I have seen, not uncommonly, I've seen flare-ups happen.
I would say exactly, because that's where we tend to head is the liver, and it just blows everything up.
Yes, 100%.
So looking at the nitty-gritty of treatment, I want to know, let's start with internal treatment options. Can you give us some little cheat sheets around what you use in each of those treatment aims? Let's start with the nitric oxide.
For nitric oxide, the treatments that I use are mainly external because the research is strongest on a few things.
Okay.
So vitamin B12 has been shown to reduce nitric oxide levels in the endothelium.
Okay.
And so this study here, it was actually an RCT, and they used only 0.07% of cyanocobalamin in a cream base.
Mm-hmm.
And after 4 weeks, the eczema score decreased by around 3 points more in the treatment group versus the placebo group.
Okay.
In my practice, I use methylcobalamin and hydroxycobalamin, and I find both work quite well. My favorite dilution is around 1 to 2%. And so if your cream looks a bit pinkish, I think that's the correct dilution.
Okay.
And I call it the pink cream.
Great. So 1 to 2% methylcobalamin or hydroxycobalamin in a cream base to help with the nitric oxide. I haven't tried that myself, so thank you. That's a great addition to my toolkit. What else would you use in treatment options?
Yeah, so and in this pink cream, I also like to add herbs to reduce Staph aureus. And so for myself, I think of how do I include different herbal antimicrobial constituents to just broaden the range of the actions and the receptors. So let's say alkaloids. For alkaloids, I use berberine, and I like to use Copsis chinensis because of the higher berberine content.
Yeah.
If you don't have it in a dispensary, sometimes I use golden seal or Oregon grape.
Okay.
And then for the resins, I love to use myrrh for the resins. And for the tannins, I use green tea extracts. And for the volatile oils, I use thyme and rosemary liquids. And I favor the liquids a bit more for the volatile oils because I find essential oils a bit too strong and sensitizing for eczema skin. So I use our flow extracts of thyme and rosemary, and I find those well tolerated. Commonly, I get asked, Ben, why do you not use chamomile and calendula? Because those are our textbook herbs. I have found quite commonly that many patients, because of the impaired skin barrier, and when they run IgE RAS tests, they are high in pollens for the daisy family. So I avoid using Asteraceae family because of this reason. And even for myself, it made me flex. So I found that it was too risky, and I get good results without using chamomile and calendula in my practice. Okay,
that's good to know. What else would you use?
Yeah, so internally, my favorite herb is Becker's skullcap or Scutellera bacalensis. For a few reasons, it ticks all the boxes for TSW. It inhibits IL-4, IL-13, TSLP, IgE. It just calms down the whole Th2 response. The flavonoids, the bivalent, the woganin have been so well researched for all these purposes. And for myself also, one big part of my herbal prescribing is energetics.
Yes.
And if we see a Becker's skullcap from the Chinese medicine angle, it's used to clear damp heat in Chinese medicine. And TSW is a hot condition. It's hot. There's oozing, there's dampness, there's heat. And so it's a perfect fit for TSW. And to segue a bit into herbal compounding, I always favor the more cooling herbs in TSW. I have seen anecdotally that patients get worse with the warming herbs like ginger, astragalus, ginseng. And a few patients told me that when they tried curcumin on their own, they felt more hot and dry. And if we see the Ayurvedic energetics, curcumin is more to the pitta side. And that may perhaps aggravate an already pitta condition.
Okay. So what's the energetics of the herbs? I love that angle as well. What about for the capillaries, strengthening the capillaries?
Yeah, for sure. So the capillaries are so important because in TSW, we often see oozing. And they because of the capillary permeability, we must enhance capillary. So vitamin C, lutein, hesperidin, our bioflavonoids. And I like to use maritime pine bark because it's also good for, it reduces inflammation, it's also anti-allergic, and it also enhances capillary integrity. And also for the nervous system, my top herb perhaps for TSW. So, whenever we think of vervain, Verbena officinalis, vervain being a nervine and a gentle bitter, it fits the TSW perfect picture of someone who is hot, who is frustrated, who is angry, who hasn't slept for days. So vervain fits all that because in our TSW patients, they're overheated, they are frustrated, and for good reasons. And so I love to use vervain tea. I have found that liquid herbs with the ethanol content have not uncommonly caused more heat and dryness among my patients. So I find tea is a lovely addition to the treatment plans.
And such a gentle way to introduce a herb into patients as well. For
sure. And vervain, passion flower, skullcap are my favorite combinations. Yes. And the last point is that for the skin barrier, I actually love to use evening primrose oil. And I dose this at around 3 or 4 grams a day. And I combine this with a fish oil and a B complex. So, the reason being that primrose oil contains gamma-linolenic acid or GLA. And studies have found that eczema patients, they can't quite convert LA or linoleic acid to GLA very well because of a mutation in the delta-6 desaturase enzyme. And in my earlier days in clinical practice, I would run the essential fatty acid profile for my patients, and I'll find that almost all of them would have mutation in the enzyme delta-6 desaturase. And it got so common that now I just don't run a test anymore. I just give them primrose oil.
So, Ben, on the favourite topic of mine, which is food as medicine, what do you think the most important thing for us practitioners to know is?
Yes. So, many TSW patients, they tell me that they have major food fear because they have done food intolerance testing, remove gluten, remove dairy, remove all the foods that were high on the test. And the eczema or the TSW did not even improve, or it got better for a while and got worse again. My goal is actually to not take out foods as much, but rather add in foods. For example, if clients have a reaction to salicylates, if they flare up with berries and avocados and tomatoes and mushrooms and citrus fruits, I suspect salicylates, and I use glycine, calcium, magnesium. If I see a histamine reaction, to canned fish, to let's say fermented foods, I may use the DAO enzyme. So that gives our patients some wiggle room because their headspace is already so maxed out. And so I avoid doing major food elimination, perhaps reducing some gluten, some dairy, but not a full removal, just reducing it. That way, then we avoid having to stress the patients out even further.
And I love that approach because there can be a lot of fear around food for these patients, for all skin patients actually, but I love that, you'll help support their body to tolerate the foods and just minimise what's really necessary too. Ben, I have learnt so much today on topical steroid withdrawal and how to look at it in a very strategic way. What are a couple of key take-home messages you want us all to learn today? I mean, what can help us get better patient outcomes?
Yes, sure. So number one is that address the endothelium first and foremost before going for the guts. Number two, we must address the staph. Whether it's eczema or TSW, the staph is a major trigger for eczema and TSW flares. Number 3 is that also set timelines and expectations for the patient, because TSW is a journey, it's a long journey, and we can quicken the process, but the process must still run its course. And therefore, setting expectations early will help. And so, in conclusion, I think that what's most important is that to reassure the patient that they are in a safe space, that this will pass, and that they will see better days again. They can wear their shorts and t-shirts again after this journey passes. And so I think that combining naturopathic care and even conventional care together can give us the best outcomes in TSW treatment.
Amazing. Ben, thank you so much for sharing your expertise on this very tricky clinical skin condition.
You're welcome, Emma. It's a pleasure to be here, and yeah, thank you for having me, and I'm glad to share my experience with all of you. Thank you so much.
My pleasure. Thank you everyone for listening today. Don't forget that you can find all the show notes, transcripts and other resources from today's episode on the FX Medicine website, fxmedicine.com.au. I'm Emma Sutherland. Thanks for joining us. We'll see you next time. This podcast is intended as healthcare practitioner education only, and it is not a substitute for medical advice, diagnosis, or treatment.
Make sure you never miss an FX Medicine episode by subscribing to us on Apple Podcasts, Google Podcasts, and Spotify. You can also follow us on LinkedIn, Facebook, and Instagram.